Have you had a positive calcium score and is it increasing? Is it scary? A lot of people are in that situation. Sometimes that increasing calcium score is not a bad thing. Believe it or not. Watch this video.
So I thought, I'll just go if I ask for a tomography from this group, they're never going to get it because it's going to be too expensive or it's not in the standard. So I'll just go down and pay for it from Cardio Risk, $200. They gave me my first CIMT, which was, again, pretty scary. I had an arterial age of 74 and I was 66. But I would like to talk about the CIMTs. I would prefer if you took this, Dr. Brewer, if you can, just to explain the numbers on it, because I could use a little help.
Sure. Actually, I think that's a great opportunity, and I will take this opportunity to go through my generic spiel. But before I do, speaking of generic spiels, a couple of points. Number one, you see me laughing so much. I don't mean, obviously, to laugh at your pain, but you volunteered, and your story is so classic. I mean, if we've heard of what I've heard hundreds of times. One of the major reasons that people give when they come to see us is, I had this calcium score, and it's really bad. And the doc gave me a bunch of misinformation. And here's another thing. You know, YouTube is a men visual. You tend to see more men on YouTube. And sure enough, there are more men that come in through the channel. And men our age, boomers, were taught from day one not to cry. But this is scary stuff because it's not like if we mess this up or the doctors that we depend on mess this up, it's not like we won't die. It's not like we won't get permanently disabled. So there's a very serious and ominous side to this stuff. Despite the fact that men our age have been taught all their life not to cry, and many of them come to me and start crying when they tell me these stories and say, I've never cried before. We get used to it. We hear it a lot. I've heard it a lot. And the next statement is, yep, I get it. I've got plaque. I was surprised. Well, I did get a calcium score. I had a positive calcium score. You're going to be fine. And a lot of people coming in to us are very concerned about positive calcium scores. Every one of them, even the ones that have cried starting off, within 3 to 6 months are looking at this saying, hey, I'm good. I understand there's risk associated with it, but I also understand the details behind the risk. I know what I am doing. I also know that it's not you doing it. You're just my guide. You're interpreting what my body's telling me. And I know that I'm stable now. I know that I've taken it probably 98% of that risk off the table, and it's not likely at all that heart attack or stroke is what's going to kill me. It's going to be something else. And even if it does, I'm also more comfortable that I'm much more likely to have something that takes me out, as opposed to something that disables me or turns me into an Alzheimer's patient for 20 years before I die. So there's a very serious side to these stories, but like you've said, the moral of the story is, despite poor leadership from our current medical population, you can do this. You can save your own life. And thank you again for sharing this story. It's so classic for what we hear.
We can understand that there's fear because if you get a positive calcium score and the first thing they tell you is, well, this is how a heart attack looks like, go to the ER when that happens. It's crazy.
Yeah, it is crazy. It's really crazy. There's another calcium score that if you can tell me how that looks, if that's good improvement or moderate improvement, or I should be working harder at something.
Well, as we know, when we prepped this, you've got another one. I'll describe both of the CIMTs first, and then we'll talk about the calcium score. The last.
Oh, I'm sorry. It's the CIMTs I'm interested in because the calcium score is kind of old news to me now. Now that I've got this tool, I don't see much point in doing them anymore.
I'm glad. The one other final thing I'll say about calcium scores before we get off of that is that quite often people come and they're very concerned and they think they're going to die because their calcium score is over 1,000. And then when they hear, well, I had a patient 2 weeks ago that was over 2,000 and 3 weeks ago over 3,000. And yes, I've had several patients with calcium scores over 4,000. Then people begin to lighten up and realize that, yes, this risk is doable. And yes, you can take it off the table. And as we'll see from what's going on with your next two CIMTs, as I interpret them, we're going to find an even more important issue. This issue where people come in, they've got a positive calcium score, they get religion, they lose the weight, they drop the carbs, they clean up their lifestyle, they lose 40 pounds. And then they go back expecting to do a victory lap after their calcium score has dropped. And they see the opposite. The calcium has increased. And then they panic. Well, that happens because calcium score is not going to show soft plaque. And soft plaque is what's dangerous. Your 2 CIMTs, as we'll see in just a second, show exactly what we're talking about in that as you continue that healthy lifestyle, you're going to continue to calcify soft plaque. People don't get that. They don't make the connection between that process with CIMT and a calcium score. They still panic when they hear their calcium score going up. Hopefully, going through your 2 CIMTs will help people understand this. So first of all, let's go back and talk about orient just a little bit. These 3 images on the right help you understand what we're looking at. If you go down to the bottom, you'll see the head where that helps us understand the arteries that we're looking at. First of all, it's the common carotid artery, which is going right through here. If you go up to the top, you see this CCA. That's the common carotid artery. Next, you'll see what we call the bifurcation or the bulb. And parenthetically, usually if we're going to see plaque, it's going to start in the bulb. Not always. Sort of like LAD is called the widowmaker, but simply because usually when you get calcium, that tends to be where that happens because of hemodynamic issues. You get turbulence, and where you get turbulence, you're more likely to get plaque. So you have the common carotid, the bifurcation, and then you have the ICA, which is the internal carotid, which goes up to the brain and therefore has some very significant direct concern regarding stroke. And you have the ECA, the external carotid artery. Now, before we leave these 3 images on the right, let's go to the very top image. That's an actual image out of a CIMT, not yours. It's a standard image that they get. And first of all, you notice the black area, and most people recognize that's the actual artery image. The black part is the lumen. Over at the CCA, you see this little white line, a thin white line. Then you see a thick, cloudy white line. The thin white line is the intima. It's that single cell layer. It's got the glycocalyx in it. And the thick white line is the media, the muscle layer that gives the structure. If you didn't have that muscle layer around the artery, the intima couldn't hold, and the arterial pressure would just blow it apart. People classically will come in and they'll say, oh, my cardiologist did an angiogram and he said I was 100% blocked, or 90% blocked, or 98% blocked in this one area, often the LAD. And so we had to do a stent. No, you didn't. One of the questions is, well, did you have angina? No, I didn't have any pain. Well, if you weren't getting blood through that 100% blocked area, why weren't you having pain? Because of this muscle layer. That muscle layer expands to allow you, routinely it'll expand to allow you to get the blood supply you need. So we think in terms of, quote, plumbing and flow, but this is a living, moving organism we are, and that artery is. So it's not like iron pipes. So now let's go back and look at one other thing in this black image at the top here before we move on. The black image at the top, you see the intima, you see the CCA, the media, and over on the right, you see this thing that says IMT. That's the intima media thickness. So this is the core difference between a CIMT and what you usually see when people get an ultrasound. The ultrasound technology is the same, the imaging technology, except they don't image, they just look for flow problems. So people will come in and they'll say, oh yeah, I got an ultrasound of the carotid. Or my patients will classically go ask their local ER or us on the corner, and they'll say, do you do CIMT? And then they'll start describing it, and they'll say, oh yeah, we do that. What they'll send us is what we call a flow study. It's an ultrasound that looks to see if there's blockage of flow. And people will hear us say quite often, that's a flow study. That's not what we're looking for. And it's true. What we're looking for in a CIMT is the thickness of this IMT space, because that area is where a plaque is going to be. You get inflammation, you get injury to this intima layer, and LDL, whatever level you have. If you're an FH patient, you've got more LDL in there. If you're not, whatever level, especially small dense LDL, will then go through these cells here in the intima space. It's called transcytosis. We used to think it was holes. It's not really holes in that intimate space. It's the small dense LDL actually passing through that single cell layer. It won't pass through the media, so it gets stuck. And that's why we can measure the space. And once we measure that space, it gives us an idea of whether or not you have plaque. If you go back over to the left and you see this arterial age that you furnace, that's how they calculate the arterial age. They will
Dr. Brewer, if you can put my picture on full screen, I can hold up a nomogram for you.
Okay, you want to try the shaky paper thing?
Yeah, I think I would consider that an honor.
You know, for those of you that remember the shaky paper days, you can look around and then use a pen and actually point to the space.
I can't do that. I'm not that good. But if you want to use that to describe it, I'll hold it still as still as I can.
Okay, so the shaky paper that you're seeing today is basically there's two lines. There's a blue line and a pink line. Along the bottom, you have age, and along the vertical, you have thickness. And so what has been demonstrated? Hundreds of thousands of patients, 10,000 patients in one study alone called the Cafe to Cave study, which you may have must referred to a few times. They've even done this on kids less than 5 years old. Unlike every other imaging technology, there's no radiation, so it doesn't have any negative health impact or danger. So what's interesting is blue lines are boys and pink lines are girls, and you see that boys tend to have more. I mean, we come out of the womb similar, but even a little bit different, even by the time we're age 5. So many of us would assume that it starts happening with testosterone and those male hormones. But that's maybe not the case, as you can see from looking at the early divergence of the male and female CIMT pattern. Anyhow, you go back, so you take that intimate media thickness that they found on clean slate. You identify it on the left side of clean slate's nomogram. Then you go along to the right and put a mark at clean slate's age, and that tells you where he was. Thank you, clean slate. We can go back to the overall image of the INT. That will then give him his arterial age. Well, this is a different. Let's go back to this first one, because you see, he did like I did. He started out at a much higher arterial age, and then he dropped his arterial age. So go back to the original, this one. So our most popular video is me sharing my own CIMT. And sure enough, when I was age 57 and you did that nomogram exercise, I had an IMT of about 87 millimeters. And while we're here, let me just go a little bit more in depth and tell you the difference, how they do this and the difference between this and an ultrasound flow study. On a CIMT, they go to the CCA, common carotid artery. They pick an area where they've got a full centimeter of flat space. They take 600 cuts using a computer. It's not completely smooth. The actual intimate media space goes up and down. They take those 600 cuts and they average them out. That's how they get the number 0.87. And like clean slate, when he was age 66, I was age 57, and my IMT was almost 0.87 millimeters as well. Now, let's go over to this next area. So looking at the nomogram study, mine was age 73. His arterial age was 74. Now, my most popular video, again, was sharing my own. Within a few months, I had just lost a few extra pounds. I agreed to go on statins because I was a statin hater until that point too. And that happens. People say you cannot reverse plaque. That's not true either. You know, we had a fella come on and he said, "This is wrong. You cannot reverse plaque. My doctor is the head of cardiology at Cedars-Sinai, and he says you can't reverse plaque." I don't think the head of cardiology at Cedars-Sinai didn't know this. I think that there was a misinterpretation of what he was saying. No, you don't usually reverse plaque, but yes, it can happen. If you go to the head of cardiology at Harvard, he wrote an article and it's there present on the internet. You can see, yes, we've seen people reverse plaque. And here are the most common two ways that it happens. Somebody that had never been on statins before going on statins, and somebody that had lost 30 pounds or more. So these things are effective. Now, then the question comes up, well, did you lose plaque or did you lose inflammation? And the reality is you probably lost. The inflammation is a whole bunch of inflammatory cells, liquid, inflammatory liquid, etc., things like that.